Hello dear students, today we are going to learn about tracheoesophageal fistula. Let's start with a case file. Here is a case of 2-hour-old male neonate developed coughing, choking and cyanosis during the first attempt of feeding, and he was born by normal vaginal delivery at 39 weeks of gestation. Antenatal ultrasonography revealed polyhydramnios. On examination, infant appeared mildly distressed with excessive oral secretions and frothing. Respiratory examination revealed bilateral coarse crackles, and abdomen was markedly distended and tympanic on percussion. An attempt to pass an orogastric tube was unsuccessful with resistance encountered at mid-esophagus. Chest radiography demonstrated coiling of the tube within the proximal esophagus, and air was present in the stomach and intestinal loops. So this is a typical case of tracheoesophageal fistula. Almost all neonates presents within the first 2 to 4 hours of birth, and they present with a typical history of coughing, choking and cyanosis during the attempt of feeding. Antenatal USG can show polyhydramnios due to presence of esophageal atresia associated with tracheoesophageal fistula, due to which in utero fetus cannot able to swallow completely the amniotic fluid, and there is increased amount of amniotic fluid remains in the amniotic sac. Examination show frothing from the mouth, which is a very common presentation, and crackles can be heard because of the aspiration, microaspiration of the food or the secretions in the lungs, and the abdomen is distended because of connection of the stomach with the trachea and via the esophagus. So air moves from the trachea to the esophagus and to the stomach, and you can see the coiled orogastric tube in the esophagus. Now let's discuss further. So first let's start with the development of the trachea and esophagus. Trachea develop from the foregut endoderm as a respiratory diverticulum from the ventral aspect of the foregut around third week of gestation, and then a septum formed between the esophagus and trachea, which is known as esophageotracheal septum, during the fourth week of gestation, and gradually this septum closes and separates the pharynx or esophagus from the trachea. And this is the classification of the tracheoesophageal fistula. Tracheoesophageal fistula is of 5 types according to Cross classification and Walk classification. The most common is type C or third B type of tracheoesophageal fistula, in which proximal esophagus is atretic. There is atresia of the proximal esophagus, and distal tracheoesophageal fistula is present. Second most common is type A, in which there is no fistula but there is only the presence of esophageal atresia. Both proximal and distal esophagus are not connected with each other, and however there is no tracheoesophageal fistula is seen. Other less common are type B and type D, and type E is a H-type fistula, in which the proximal and distal end of the esophagus is partially atretic and partially connected with trachea also. So its presentation occurs usually in later in life, and it is more benign type of tracheoesophageal fistula. Clinical presentation of tracheoesophageal fistula. In neonates, a classical triad of coughing, choking, and cyanosis occurs after the attempted feed. Excessive salivation and drooling is very common. Abdominal distension can be seen due to the distal uh, tracheoesophageal fistula, and you are not able to pass a nasogastric tube more than 10 to 12 centimeters of uh, the esophagus, and it coils in the proximal pouch, which can be seen on X-ray. H-type tracheoesophageal fistula usually presents in older children or in adult life with recurrent cough while feeding, and recurrent pneumonia and failure to thrive. Common associations with tracheoesophageal fistula include vectoral sequence, Char syndrome, trisomy 18 and 21, and Digeorge syndrome. So, vectoral sequence is an acronym for uh, vertebral defect, anorectal defects, cardiac defects, tracheoesophageal fistula, and R is for the renal defects, and L is for the limb defects. Char syndrome is an acronym for coloboma ophi, heart defects, atresia of the choanae, mental retardation, genital hypoplasia, and ear abnormalities. Trisomy 18 and 18 is known as Edwards syndrome. Trisomy 21 is Down syndrome. And DJR syndrome is a deletion of 22q11, and it is associated with many other defects, include the absence of thymus and other cardiac abnormalities. Now, coming to the diagnostic approach towards tracheoesophageal fistula, the most important thing is the clinical history of coughing, choking, and cyanosis and drooling of saliva. And attempted NG tube insertion feels resistance around 10 to 12 centimeters of the length, and this is a um, very important sign, and you can see the coiling of the tube in the proximal pouch, and distally you can see the air in the stomach, and you can also localize the fistula by with the help of bronchoscopy, and if carefully performed you can also do the contrast study in some cases. Now coming to the management of the tracheoesophageal fistula. Management consists of two parts: initial stabilization and second is the definitive surgical management. Initial stabilization is a pre-operative care phase in which the goals are to prevent aspiration and to maintain the ventilation. Keep NPO, that is nil per oral, and keep head end elevated up to 30 to 45 degree to prevent aspiration. Use wide bore double lumen tube, which is also known as Raplogal tube, to for the continuous low pressure suctioning of uh, the proximal pouch. In this image we can see this is the Raplogal tube, and it has two parts: the suction port to suction for the continuous low pressure suctioning of the secretions which are coming in the esophagus or proximal pouch of the neonate, and second part is the flush part, used to the flush the secretions to with the saline. In this image we can see how it is inserted. And other things we have to know that we have to avoid bag and mask ventilation, because bag and mask ventilation causes the further abdominal distension, which is dangerous, and we have to use endotracheal intubation because it bypasses the fistulous opening. And other things we have to consider are IV fluid, use of glucose and electrolytes, and nutritional support. And other thing is the use of broad spectrum antibiotics if aspiration or pneumonia is present. And early screening for the associated anomaly should be done with use of echocardiography and general inspection. Definitive surgical management include the treatment of the tracheoesophageal fistula with the ligation of the fistula and end-to-end anastomosis of the esophageal atresia. Intraoperative priorities include secure identification and division of fistula, preserve nerves, and use of tension-free well-vascularized anastomosis. In isolated H-type tracheoesophageal fistula division and closure is only required, and in sometimes you can see the long gap atresia, which should be managed with staged repair and with delayed anastomosis, and gastrostomy for feeding and decompression should be done by the time. And sometimes you have to replace the esophagus by gastric pull-up or colonic interposition. This is in the large gap atresia. Now coming to the post-operative care and complications. Early post-operative care include respiratory supports, which focuses on the adequate ventilation and adequate oxygenation, analgesic support to manage pain effectively, and feeding should be done only after the contrast study to exclude any leak. What are the key complications and their management? Key complications include anastomotic leak, anastomotic stricture, gastroesophageal reflux, and recurrence of tracheoesophageal fistula and tracheomalacia. Anastomotic leak should be managed by antibiotics, drainage, and other supportive management. Small leaks usually seal spontaneously. Anastomotic strictures should be treated with serial endoscopic dilatations. Gastroesophageal reflux can be treated with acid suppression, positioning of the baby to with head and elevated, and other feeding modifications. And in refractory cases, you can do fundoplication. For recurrent tracheoesophageal fistula, first evaluation should be done with bronchoscopy and surgical treatment can be done. Long-term follow-up with multidisciplinary approach should be done, and evaluate for the any sign of dysphagia, respiratory infections, growth monitoring should be done, and speech therapy should also be done. Management of gastroesophageal reflux and stricture dilatation should be continued, while vaccination and infection control should also be continued. Usually outcomes are excellent, more than 90% cases resolve. However, persistent functional issues like esophageal dysmotility, chronic cough are very common. Prognosis of tracheoesophageal fistula. Prognosis primarily depends on the birth weight and associated anomalies, especially the cardiac anomalies. So favorable prognosis occurs in term infant, birth weight more than 2.5 kg, no major associated anomalies. And such cases have more than 90% survival with good prognosis. Poor prognostic factors include the low birth weight, especially less than 2 kgs, and if it is very low birth weight, then it is very poor prognosis, and significant cardiac anomalies are associated with poor prognosis. Pneumonia and sepsis are also associated with poor prognosis. Long-term outcomes depends on other risk factors of like GERD, stricture, and feeding difficulties. Most child achieve good quality of life after the treatment. However, continuous follow-up care is required. Now coming to the summary of tracheoesophageal fistula. Tracheoesophageal fistula is an abnormal communication between trachea and esophagus, and its incidence is 1 in 2500 to 4500 live births. Most common type is type C, which is distal tracheoesophageal fistula with esophageal atresia. It is caused by failure of foregut separation during 4 to 6 weeks of embryogenesis, and it is strongly associated with vectoral association, presents with drooling of saliva, choking, coughing, and cyanosis during feeds. Angi-tubes cannot pass, and X-ray shows coiled tube with air in the stomach. Initial management include keeping the newborn nilparoral with head and elevation, and use of continuous suctioning with raplogyl tube, and avoid the back mask ventilation. Definitive treatment include surgical fistula ligation and esophageal anastomosis. Common complications are anastomotic leak, stricture, GERD, and recurrent tracheoesophageal fistula and tracheomalacia. However, survival is more than 90%. So that is all for today. Thank you.